hosted by School of Community Wellbeing, which is the part of Living Labs Institute. So Samagama Talks is a space for conversations, dialogue, discourse around learning and about place-based practices, which is organized by School for Concentration. In Living Labs Institute, we have different schools, and we will be hosting multiple talks in the future also. So, in Living Labs Institute, all our living engagements and courses are informed by our work in Bidar, Kundapura, and Channapatna. We follow place-based transdisciplinary approach of learning rooted in place, people, past, and culture. So, we want to reimagine what development looks like from the perspectives of grassroots. We have with us Dr. Sylvia Karpagam, and today we'll be talking about understanding social determinants of health and how food practices shape nutrition. And this conversation will be in bilingual. And as part of School for Community Wellbeing, we are trying to ask these kind of questions like, what does it mean to live well together? And instead of treating well-being as a service delivered by systems, like how can we approach it as something which is grown from a place of care by the people and shaped in the place itself? And Dr. Sylvia Karpagam is a public health doctor with around 18 years of experience. She has worked in health and social determinants from a perspective of rights and with many communities, networks, and as well as human rights organization. Ma'am, if I've missed out something, you can also add.
No, it's fine. We'll go to the session.
We also have Ishwari with us. Ishwari, do you want to introduce yourself? I can go after you.
Hi, everybody. This is Ishwari. I am also a fellow with the School of Community Wellbeing at Living Labs Institute. I have been closely working on reproductive health cultures engagement in Bidar. It is a long-term collaborative archive imagined with over 20 caste and craft-based communities in Bidar. But currently, we have engaged with communities such as the Muslim community, Komti, Jingar, Lambani community, Kurubas, Kumbara communities. And with them, we are co-working to document their knowledge about reproductive health and how this knowledge has historically moved in the form of songs, rituals, remedies, objects, and many other forms. We are working with different community members within these communities to also curate these uh, different reproductive health ceremonies, such as the puberty ceremonies, the birthing practices, different herbs, what are the oral histories these women have, how are we documenting their personal experiences. The purpose is also to make this local knowledge accessible locally, so women as well as community health workers can draw from these socio-cultural practices as well as practices that are there in the former healthcare systems. So yeah.
I am Sangeeta, and I also work as a fellow in Living Labs Institute. My work has revolved in around rural areas of Tamil Nadu and now in rural parts of Karnataka. I mostly work here in Kundapura with this initiative called as Samagra Arogya, where we are trying to imagine how like panchayats can work with the people and see services not just as welfare but also from a place of care. And I also anchor the different engagements in Living Labs Institute. Yeah. So I can just give a small introduction about Samagra Arogya. So in Samagra Arogya, we work with 7 panchayats in Kundapura, and we work with different collaborators from ASHA workers, frontline workers, Sanjeevani Sangha workers, GP members, and we are trying to look at how social determinants of health is getting manifested in that place, because it's a very transitional place, lot of migration and a lot of old population left behind by the younger people migrating to other places, and the landscape is also shifting from agriculture to horticulture and industries. So there is a constant change when it comes to looking at health. So we are currently like experimenting and working on that. So with that, I would like to start this session with the first question of what social determinants of health is, from a context of like Indian health practices, like how is it yeah, from here, because in WHO we have gender.
ಇದ್ರೆ ಸಾಮಾಜಿಕ ನಿರ್ಧಾರಕಗಳು, ದಟ್ ಮೀನ್ಸ್ ಸೋಷಿಯಲ್ ಡಿಟರ್ಮಿನೆಂಟ್ಸ್ ಆಫ್ ಹೆಲ್ತ್, ಆಲ್ಮೋಸ್ಟ್ 50%, ಆಲ್ಮೋಸ್ಟ್ 50% ಆಫ್ ಇಟ್ ಅಫೆಕ್ಟ್ಸ್ ಅವರ್ ಹೆಲ್ತ್ ಔಟ್ಕಮ್ಸ್. ಸೊ ಸಪೋಸ್ ನಾವು ಇಫ್ ಯು ಲುಕ್ ಅಟ್ ದ ಮೆಡಿಕಲ್ ಫ್ಯಾಕ್ಟರ್ಸ್, ಸಪೋಸ್ ನಮಗೆ ಮೈ ಹುಷಾರಿಲ್ಲ, ಜ್ವರ ಬಂದಿದೆ, ಬೇರೆ ಕಾಯಿಲೆಗಳು ಬಂದಿದೆ, ಹೆಲ್ತ್ ಏನು ನಾವು ನಾರ್ಮಲಿ ಹಾಸ್ಪಿಟಲ್ಗೆ ಹೋಗ್ತೀವಿ ಅವೆಲ್ಲನೂ ನೋಡಿದ್ರೆ ಅದನ್ನ ನಾವು ಕ್ಯೂರೇಟಿವ್ ಅಂತ ಹೇಳ್ತೀವಿ. But if you look at social determinants, they are almost 50%. So for example, now, like you said, gender is one of them. Gender is a social determinant. So between women and men, there are different health outcomes because of gender, and this is it's not a genetic, or it's not a species thing. It's a social construct, because of which women have different health outcomes to men. And ಅದೇ ತರ ಇವಾಗ ನಾವು ಸಮಾಜದಲ್ಲಿ ಬೇರೆ ಬೇರೆ ವಿಷಯಗಳು ನೋಡಿದ್ರೆ, ಜಾತಿ ಒಂದು ವ್ಯವಸ್ಥೆ. ಜಾತಿ ಬಂದು ನಮ್ಮ ಆರೋಗ್ಯ ಔಟ್ಕಮ್ಸ್ ನ ಡಿಸೈಡ್ ಮಾಡುತ್ತೆ. ನಾವು ಯಾವ ಯಾವ ಜಾತಿಯಲ್ಲಿ ಇದ್ದೀವಿ, ಅದು ನಾವು ಇರ್ತೀವ, ಎಷ್ಟು ಆರೋಗ್ಯವಾಗಿರ್ತೀವಿ, ಅಥವಾ ನಮ್ಗೆ ಆರೋಗ್ಯ ಅಡ್ಡ ಪರಿಣಾಮಗಳಿರುತ್ತಾ, ಇದು ಜಾತಿ ವ್ಯವಸ್ಥೆನೂ ಡಿಸೈಡ್ ಮಾಡಿಸುತ್ತೆ. ಬಿಕಾಸ್ ದ ಕಾಸ್ಟ್ one belongs to can also affect one's access to healthcare, one's livelihood, one's income, one's access to other determinants of health, for example livelihood, nutrition, so, and water, sanitation. So all of those, caste is a very important factor. And increasingly religion. ಸೊ ಧರ್ಮನೂ ನಮ್ಮ ಆರೋಗ್ಯನ ಈ ನಡುವೆ ಡಿಸೈಡ್ ಮಾಡ್ತಾ ಇದೆ. ಫಾರ್ ಎಕ್ಸಾಂಪಲ್, ನಾವು ಕೋವಿಡ್ ಟೈಮಲ್ಲಿ ನೋಡಿದ್ವಿ, ಕೆಲವು ಸಮಾಜಗಳಿಗೆ, ಕೆಲವು ಧರ್ಮದಿಂದ ಬರೋರಿಗೆ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆಯಲ್ಲಿ ಒಳ್ಳೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಸಿಗ್ತಾ ಇರಲಿಲ್ಲ. ಅಲ್ಲಿನೂ ಭೇದ ಭಾವ, ಅಲ್ಲಿನೂ ತಾರತಮ್ಯ ಆಗ್ತಾ ಇತ್ತು. ಅಂಡ್ ಯಾಕೆ ಅಂದ್ರೆ ಅವರು ಒಂದು ಪರ್ಟಿಕ್ಯುಲರ್ ಧರ್ಮದಿಂದ ಬಂದಿರೋರು, ಅಥವಾ ಒಂದು ಪರ್ಟಿಕ್ಯುಲರ್ ಜಾತಿಯಿಂದ ಬಂದಿದ್ದವರು, ಅಥವಾ ಮೈಗ್ರೆಂಟ್ ವರ್ಕರ್ಸ್. ಇವಾಗ ಮೈಗ್ರೆಂಟ್ ವರ್ಕರ್ಸ್ಗೆ ಒಂಥರ ಟ್ರೀಟ್ಮೆಂಟ್ ಸಿಗ್ತಾ ಇತ್ತು, ಇದು ಯುನೋ ವರ್ಕ್ ಫ್ರಮ್ ಹೋಮ್ ಅವ್ರಿಗೆ ಒಂಥರ ಟ್ರೀಟ್ಮೆಂಟ್ ಸಿಗ್ತಾ ಇತ್ತು. ಸೊ ದೇರ್ ಆರ್ ಲಾಟ್ ಆಫ್ ದೀಸ್ ಫ್ಯಾಕ್ಟರ್ಸ್ ವಿಚ್ affect not only one's health but also one's access to healthcare. When you go to a hospital, for example, I used to work in a ART center. It was a tertiary center, and if someone who is, say, a sex worker or someone who is transgender, if they come to the hospital, the way they are treated is very different from, say, someone who is elite or English speaking, urban, or well educated, or even people with money are treated. So within the system itself there is discrimination. So that is what we say, as the social determinants. And these not only affect, like what I said, healthcare access, but also policy making. ಇವಾಗ ನೀತಿ ಮಾಡೋರು ಇದರಲ್ಲಿ ಎಫೆಕ್ಟ್ ಆಗ್ತಾರೆ. ಫಾರ್ ಎಕ್ಸಾಂಪಲ್, ಇವಾಗ ನೀತಿ ಮಾಡೋರು ಎಲ್ಲರೂ ಪುರುಷರಾಗಿದ್ರೆ ಅವರು ಮಹಿಳೆಯರ ಇಶ್ಯೂಸ್ನ ಅವರು ಅಡ್ರೆಸ್ ಮಾಡಲ್ಲ. ಅದೇ ತರ ಎಲ್ಲರೂ ಒಂಥರ ಸಿಟಿಯಲ್ಲಿ ಇರೋರು ನೀತಿಗಳು ಮಾಡಿದ್ರೆ ಅದು ನಮ್ಮ ಹಳ್ಳಿ ಪ್ರದೇಶದಿಂದ ಇರೋ ಜನರಿಗೆ ಕೊಡೋರೆಲ್ಲ ಒಂದೇ ಜಾತಿ ಅಂದ್ರೆ ಅದು ನಮ್ಮ ನೀತಿಗಳನ್ನು ತುಂಬಾ ಅಫೆಕ್ಟ್ ಮಾಡುತ್ತೆ.
Thank you, ma'am, for critically explaining what social determinants of health mean in the context of public health in India. As a follow up to that, then how do we identify and respond to these social inequities that you say, caste, gender, religion, rural, urban, also, as you pointed out, when it comes to nutrition, especially among these caste and gender marginalized, migrant, and informal laboring communities?
So I mean, we already said that how the kind of people who talk about certain issues, it makes a difference, and that is very, very visible in the field of nutrition. We see that so on the one hand we have the research. So the research is very sound. We have research in India itself which says certain things, and on the other hand we have communities who have like what you're saying you're working on. They have very deep understanding of nutrition, they have knowledge, and they work with what they have. And we have also visited and examined some of the children in some of the Anganwadis in these communities, and we have found them almost as healthy as the children in the wealthiest quintile of NFHs. So it's the people in the middle who are the problem. It is the people who are making the policies, the people who are occupying the space, like researchers, academicians, elected representatives, media, doctors, and especially we are seeing with the faculty lot of misinformation. From where they get their knowledge is not from science, it's not from evidence, it is what their grandparents have told them. It is predominantly that which is being occupying all of these spaces, and it is therefore directly contributing to malnutrition. It is contributing to a lot of misinformation and also directly contributing to malnutrition. And because they occupy power and because they occupy position, they also influence the kind of policies that are coming out in the country, and of course definitely in Karnataka we're seeing that. So, and the other thing that we're seeing is that the international organizations, for example, you have, Bill and Melinda Gates Foundation, you have Eat Lancet Commission, which are very much invested in opening the market for food. So they want to bring in packaged food, they want to bring in ultra processed foods, they want us to move away from food sovereignty and dependence on our own ecosystems, food ecosystems, which is sustainable, which is cultural, which is nutritious, and depend more and more on these groups. And these are sitting on a policy making table and they are making decisions for us. So, for example, we have fortification, we have, the pre-packaged foods, we have ready-to-eat foods. These are the things that are being promoted. And these commissions are saying that India should be a model for the world. They're saying India is a Sasyahari, vegetarian country, and which is not true. If you look at the percentage, it's only 20% who self-identify as vegetarian, and even they are not technically vegetarian because they eat animal source food, which is milk and dairy. So the product from the same animal, one product is polluted, it's untouchable, it is dirty, it is criminalized, and another product from that same animal is pure and not even just pure, it's like ultra pure kind of a thing. But your ghee is just fat from an animal, your Milk is also from an animal. In terms of composition, it's very much similar. So that's the politics, and I think it also affects the economics. It also affects nutrition. It also affects culture, because increasingly people are being told, they are being told you're cruel to an animal, or they're told you're causing climate change. I mean, some of the poorest children in the country are being told that you are responsible for climate change, and they're not telling people to cut down on, you're importing things to fortify the rice here. You're exporting beef from here, you're exporting egg from here, and that is not a problem. If we just if we just stopped exporting food, healthy food, till India malnutrition improves, we would have solved the problem, sustainability problem, every problem that people see is will be sorted if we stop exporting nutritious foods. But that's not going to happen.
Yeah, that's something we observe in Kundapura coastal side also. The fishes, the good catches are being exported immediately. And the people's food habits are also changing because they are not getting good quality food and like good quality fish. So they are moving to like chicken and or like other sources. So that is something we have also observed in our work.
Mhm.
And so in Bidar, we have worked with these different communities like Ishwari mentioned, Jingar, Komti, Kumbara, Lambani, Kurba, and they all carry this intergenerational knowledge. Like you mentioned, they have their own practices of taking care during pregnancy and like during different like stages of thing. So like how can that knowledge be integrated into a formal system? Can that should or can that be integrated into a formal health system where these kind of generational intergenerational knowledges from these communities can also play a part from a social determinant lens?
See, I think first, people knowledge should be documented. I think then it's also important that it is validated. I think more and more people uh, are being told, that what they're doing is wrong, that they're ignorant, that we are the experts. So, for example, I was part of a group which was documenting the practices of the traditional birth attendants, or the suligitis, or what we call in Karnataka. These were mainly Dalit women. Again, it was oral history being passed either to the daughter or to the daughter-in-law, and they had such scientific practices, such evidence-based practices for delivery. And at the same time, they were women who play an important role in the life of the person who's pregnant, of the woman who's pregnant. So they know everything about her. They know what she doesn't like. They know what she doesn't like to eat. They know someone is more tolerant to pain or less tolerant to pain. Who makes her more comfortable, who doesn't make her comfortable. So all that knowledge this person has. And so, for example, some of the practices which now are being adopted into the allopathic system is this, the position of labor. If you go to hospital, you will see the woman is lying on the bed with her feet up, and then they're saying push, push. How is she supposed to push? You're supposed to work with gravity. But the Sulagiti, if you see, she will be sitting in whatever position is comfortable for the woman. The woman is primary. So she'll be holding something, or she'll be squatting, she'll be any position that's comfortable, and the person who doing the delivery is the one who's adjusting. And so she works with the body, she works with the gravity, she works with what is comfortable for the woman to push the baby. We also have, and now in allopathy they're talking about it. They're saying, after so many years of saying push, push, now they're saying, okay, let's listen, instead of just saying push. Then you also have the placenta. If you see in an allopathic hospital, they will just cut the placenta and throw it in the dustbin. But the dai or sulagiti, for them it's a life. It has life. And when it's delivered, the kind of care they give, and they will not cut the umbilical cord till the placenta is delivered. and they will wait for some time. They use a placenta if the baby is not crying, or if the baby is not moving, or if the baby is cold. They use a placenta to stimulate the baby. And now, if you see in allopathy, they're talking about allowing the placenta, you know, without cutting for some time, and they say that helps reduce the anemia in the baby. And also there's one more practice where the woman is made to sit on a cot with a kind of a a coir cot which has openings, and they put coal under her, and they put neem and turmeric so that the smoke and those fumes can go up. On the one hand, it also helps to warm her. On the other hand, it also acts as antiseptic. It's a natural antiseptic, and now people are talking about neem, and in fact, the international companies wanted to patent India's neem and turmeric. Uh, in India, they they came in, like, even we were taught that the biggest cause of maternal deaths is because of the home births, home deliveries, and therefore they criminalized home deliveries. They said you should have 100% institutional births. Women were shifted to the hospitals, and now what we're seeing is even the primary health center is being broken down. It is being broken down very systematically. They've removed the doctor, they've removed trained doctor, they removed the medicines, they removed delivery options. So people have to move further and further away from their homes. They have to come to a city, or they have to come to a district hospital, or they directly refer to a corporate hospital. The cost of deliveries is anywhere between 70,000 for a normal delivery, 1.5 lakhs or more. I'm sure it's more in some of the other hospitals. And the doctor, the gynecologist, is the they cannot wait, because if time means money, so they will not wait for a woman to deliver normally, and therefore the cesarean section is going up to 65-70%. Of 100 women, 70% are having a cesarean section, and that affects her quality of life. It means every delivery after that has to be a cesarean section. And even if you look at these young doctors in the primary health centers, barely trained for like 5 years, obstetrics and gynecology for barely few months, they become the experts. And the way they talk down to women, the way they talk down to families, they're very disrespectful. In fact, the Suligitis, when they go there, they yell at them and say, because of you all these problems are happening. They ask them to wait outside. And when the women asked the government, they said, we've suddenly lost employment, do something. The government said, if you want, we can hire you as cleaners after delivery. So after delivery, you can clean the blood or clean everything, and that we can pay you for it. And I think that is also very representative of how caste operates. So these are mainly Dalit women. They have knowledge, they have wisdom, they have traditional practices, they have a certain respect. Of course, even in these homes, after the delivery, the houses are purified, which is a different kind of casteism. But to say that all you are limited to is providing labor of cleaning or whatever the so-called unclean occupations, it's just reinforcement of the same thing. And it is not that women are any happier, it's not that labor has gotten any better, or maternal deaths has gotten a good experience for a lot of women. So I think what we are doing is, and but ironically, you have these big hospital birthing centers in the city which will say, you want natural delivery, come, we'll do it for you, but pay us a huge price. So it's the irony of that whole thing.
To the process of commercialization, and we've also heard with the different communities we have worked with, the younger generations are also hesitant to even have pregnancy. And in our work with different communities, we also see how these reproductive health knowledge and practices that you talked about also depend on different circumstances, like whether a woman can afford things like dry fruits after childhood, or whether she has the whether a younger woman has emotional and mental support at home during menstruation, or whether a woman can actually rest 40 days after childhood, the recovery window period that is usually talked about, whether she can actually rest, because most women right after pregnancy are put to work again. From your work and perspective, how do you think these kind of um, inequities and realities fit into the social determinants of health, and how such a framework, such a intersectional framework in India will be helpful in understanding these sort of community practices?
I mean, see, the one thing is not to romanticize a lot of these things, and it's not that, you know, people older in older days used to live in with lot of with plenty, and then they used to, you know, be very healthy. So it's not that. I think the problem is that if you want a state to be healthy, you cannot have urban elite. Women deciding what is reproductive health. I mean, women is one thing, but sometimes men also deciding what is reproductive health, what women should be doing, where they should be going, how much rest they should be getting, how much they should be breastfeeding, and all of those things. Um, but at the same time also removing all of those in other ways. So if, say, I mean, with migration, with people losing access to traditional, say, ways of living, where, see, for example, rice is being fortified at a universal level, so people cannot consume rice that they grow. They have to give it to a company compulsively. I mean, over time it will become almost illegal to eat your own rice. You have to give it a company. The company will fortify it and it will sell it back to you at a marked up cost. It will have a shelf life. So basically, if you don't consume it within a certain period of time, you have to dispose it. That's what the company is going to say. Bringing in pesticides, bringing in products that people are not used to and people don't understand. So water is getting contaminated, and livelihood, people are losing livelihoods, they're losing access to uh, things that you need for basic living, and therefore migration is increasing. And with migration, like you said, people are losing the access to even to their own knowledge systems. And it I mean, for to so now to say that let people go back to their traditional ways of life, I don't think it's possible in a practical way. But I think it's important that people who make all these decisions, they listen more, and they're more respectful, and therefore we try to get the best of all of these knowledge systems, and so that it's not the best situation for everyone, but at least it's less unequal, or less hierarchical than what it is now. uh, I mean, that's what I can think of, but I don't know. Maybe you all have some thoughts from your own experiences.
Yeah, so from drawing from that, so we have observed in one community, Koraga, they are a scheduled tribe community, and they traditionally used to live in forests, and now they are displaced and given land in the villages, but they can't hunt or like go have a livelihood from the forest anymore, which is illegal. And when we talk to the like ASHA workers, people from the panchayat also, they say that the Koraga people get support from ITDP. They get all these food packets to support their nutrition from ITDP, but they sell it. That is what the claim is. But when the reality is, it's poverty. Like they do not have like uh, way to generate income in a very that kind of help has not been provided. So they do whatever daily, like kuli kelsa, mane kelsa, bavi kelsa, which is like very hard labor, and that is not enough to run like a family. So how can like so how do like we handle this, tackle this when looking at, because we have these different kinds of vulnerable communities still who are struggling with lot of nutrition issues, but they would have been healthier in the olden days, but now it has become difficult because the system has also changed. So how do we challenge that, like how do we face that?
See, in India, it's we have like a lot of food diversity, and food diversity is not eating different colors of rice. It's not like one day eat tomato rice, one day eat lemon rice. That's not diversity, which a lot of people actually think is. And it's also not like replacing rice with millets, because they still come under the same food group. So if you look at food groups, we usually talk about six food groups. So you have the cereals and millets, you also have the pulses and the legumes, you have the milk and dairy products, you have eggs, and then you have the fruits and vegetables, you have also the meats and fats and oils. And so within that, there is a lot of variation that people can have. So if people are used to eating a certain kind of plant, we have spoken to some communities and they just rattle off a list of suppos that they eat. So you recognize that and you validate and legitimate and support that, rather than saying all of you should eat one kind of sopu. Like it's not like everyone should eat menthia sopu, everyone should eat spinach or something. You widen the scope in each food group. And the same with, say, meat. Instead of saying, I mean, first of all, they say don't eat meat, which is unscientific. But even when people eat, like you said, widen it. If people are used to eating certain animals, if some are used to eating ants, make ant chutney, or some are used to eating beef or pork or fish or crabs. There's a lot of like what they grow in the fields. There's also coexistence of a lot of the small fish and a lot of small crabs and other things which people consume and enjoy. There's dry meats, there's dry fish. So widen the scope of that, allow people to eat what they traditionally used to eating. I think that is important. Same with fats. People eat, they eat butter, they eat ghee, they eat animal fats. So if you're cooking the animal, the meat in the fat of the animal, and if some oils, people get oils, they produce it locally. Encourage all of those things instead of pushing, say, these cheap seed oils, refined oils, and pushing that into people's plates, pushing millets into people's plates which they're not used to. If someone is eating and we're seeing that in schools, the children are not being allowed to eat their foods in school. It's being criminalized. Children come home and say we don't want to eat these foods. So in effect, what you're doing is you're narrowing the diversity options for people. And it's a very planned and deliberate move, because you're always saying those foods are bad. You're saying those foods are disgusting, and you attribute a lot of bad qualities to those kind of foods, which is not of any scientific basis, and therefore you minimize people's plates, the quality of their plates. And this whole vegetarianism of the rich is very different from what they push on the poor. So they have access to diversity. So even if they are vegetarian, it's very diverse. So they have sprouts, nuts, and paneer, and curd, all kinds of things. But what is the vegetarianism of the poor is just cereals, the cheapest. And if they, if people say, oh, it's a very cereal heavy diet, they'll say, okay, then we'll give them millets. But that's still the same food group. So I think, yeah, that is a big part of the problem. And internationally, I think, again, the corporates have been very instrumental in legitimizing this caste narrative of India. So earlier they used to say saturated fats are bad. That has been disproved. Earlier they said cholesterol is bad. That has been disproved. Now they're saying meat itself is bad. With they sharing studies which don't show causation. They might show association. So, for example, if I'm talking to you and I start coughing, someone can say, "Oh, you're doing a panel discussion with living labs causes you to cough." That's association. But if every time I do a session and I'm going to be coughing, and when I don't do the session, I'm not coughing, then that is causation. I have to prove that. So that is it is as ridiculous as that. They use association studies to say it's causation, and then the people who invest in pharma, the people who benefit from pharma, from big food, there's a lot of conflict of interest. And now in India, we have Akshay Patra Foundation, which it's they don't even pretend to be not castes. They don't even say we are not castes. They say yes, we are castes. And whatever they talk about is castes. It's not evidence based, and they are promoting sattvic foods. Um, Sattvic food again. So we also had the national education policy had one document which was called the health and wellness, I think, a document, and they talk also about this. So they list all these sattvic foods and they say they are good for your health. Tamasic foods which are not good for your health. So all the tamasic foods are what traditionally people eat. So your meat, your eggs, your onion, garlic, all of that is tamasic. And then they say eat what your grandmother used to cook. So basically, what they're saying is only a certain kind of grandma is legitimate in the country. The grandma who makes dry fish, the grandma who makes pork, who makes beef, who makes nice, tasty fish, egg curry, or whatever it is that people enjoy, is not a legitimate grandmother. It's only the sattvic, like Sudha Murthy is a legitimate grandmother. She, with her, sanitized spoons, is the perfect grandmother. But yeah, all the others are not welcome. So how will you have diversity then?
True. Even the point you were mentioning about students not having access and students having restrictions to food. In some of the work we did with the Lambani community, the children that are there, at home they eat diverse meat. And when it comes to them taking lunchbox to school, they choose what to say. There are, even if it is a low budgeted private schools, where a lot of students from these middle class and different caste groups come, there are restrictions that you can't even have egg bringing in your lunchbox. And even at university level, as you mentioned, the way the hostels menu is decided, even for it also differs from what is the menu for girls hostel versus the boys hostel. So caste and gender plays an important role in systematically restricting the kind of nutritional food and access. As a follow up to that, caste, as you also mentioned, it decides who cooks, who's the one who's slaughtering, who is the one who is serving it, who gets to eat first. But in public health formal sector, this is something that is rarely being talked about. And workers in these food systems, be it butchers or domestic workers, anganwadi cooks, uh, all of their perspectives get sidelined or excluded. What does then caste sensitive health policy look like from your perspective?
Um, I mean, you have the health policy, you also have the food policy, the nutrition policy, and in terms of health system, I think there's a lot of things that need to happen. You have, for example, what you're talking about, discrimination. You have discrimination by the health system. You also have discrimination within the health system, and we saw that very clearly during the COVID pandemic. within the same system, the way the doctors are treated is different from way nurses are treated, from the way the cleaners are treated, the people who handle dead bodies, the sanitation workers, the ASHA workers. So the ASHA workers, again, many of them are Dalit women, who, who are not very educated, in the sense they identify women who have studied, I think, up to 10th or 12th standard, and they have placed the entire burden of the health system on the shoulders of these women, put them at risk, calling them activists, paying them an honorarium, not even paying them minimum wages. These are women who have to depend on an entire structure just to get basic wages. So, she has to accompany the woman to the hospital. We see ambulances are dysfunctional in many parts of the state, even including in urban elite, smart city Bangalore. Um, so placing the burden of the health system on women, not paying them, again, it's very exploitative. And these women face a lot of verbal harassment, they face sexual harassment. They have to, go with a pregnant woman in very difficult circumstances, and if she misses out any of those things, then she's not paid. So they have protesting for very minimum, like minimum wages. And we also see that with, the people who are working within the hospital, say people who are working in mortuaries, people who are handling the waste. There's a lot of occupational hazard that they are exposed to chemicals, exposed to physical, hazards, things that they lift. And if you see the Parakarmika as a kind of vehicle that is given to them, that whatever that they push, there's no need to give them something that is dignified, that, is doesn't cause them extreme health hazard. Imagine pushing that with a lot of garbage for days and months and years. Again, with I mean, now they have been made permanent, but they were on contract for a very long time. So the health system itself is very unequal, it's very discriminatory. But of course, there is also what the health system is doing to people, in the sense, who goes to the medical colleges, who are the kind of students who go, is it accessible to, young people from marginalized communities. Like right now, the government is thinking to privatize, hand over district hospitals in 11 districts to private medical colleges. So neither people from these communities can study in those medical colleges, nor can they access the district hospitals. So that is what is happening. There's also the health insurance model, which is just a system to route funds to the private sector. The every time a law is brought to regulate the private sector, these doctors come out and they protest in huge numbers till the law is diluted. So there is, of course, a lack of regulation, but there's also personal ethics. Like, there's only so much you can regulate a system. This whole idea of personal ethics itself, I think, is a problem because of the kind of people you're bringing into the system. There are people who believe in discrimination, they believe in hierarchy, they believe that only certain people should have access to resources, and then you're putting them into a system and pumping money into the system. So the health system itself, I don't think it will change unless there's a lot of like, I think Tamil Nadu to some extent has changed it because of the reservation policies. The affirmative action brings in people who have a social awareness, who have social consciousness. And I think that's important. Representation, I think, in all of these places, education, health, policy making, I think media, of course, media talks nonsense about nutrition. They keep reinforcing the same old casteist notions. So I think unless there's representation from these communities, which are traditionally being left out, it's not going to change much. I mean, not that not that it's going to be the only thing. It's not like you bring in and therefore things are going to change. People have also bought into some of these notions. It's also like what you're doing, documenting. I think validating, legitimizing these practices are very important. Bringing it to mainstream discourse, I think it's very important.
Yeah. Uh, so we do see that private hospitals are going up and PHCs are coming down. And even if PHCs are there and even if it's well equipped, people are hesitant to go there and get services. Even if it is going to cost them a lot, they want to take out a loan and maybe go somewhere like 30 kilometers away to a main city and get access to like the best uh, medical services. So this kind
The
of
best
trust.
is debatable, but okay.
Yeah, oh,
More
like
expensive.
according to the people, yes.
Yeah, 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 yeah.
Yeah. So there is this lack of trust when it comes to like government institution, and clearly people do not want to go there. And how can like local panchayats or like local institutions change this and bring back some conversation on some kind of equity to access these infrastructures which are already there?
See, the one thing that we have seen is if there are good functioning public facilities, uh, less and less people are likely to, or more and more people are likely to use it, and less likely to use something which they have to pay for. And if you want to bring in a private player, you have to parallelly destroy a public system. So if hospitals which are publicly run, public based on public funds, people do go there. I think we have seen that very often. But over the years, what is happening is it's not consistent. There is underfunding. So, for example, if there's a doctor in the daytime and not in the night, so if you're going there for your pregnancy checkup, and then you're scared that in the night the doctor may not be there, you might directly go to a private facility, or you might go there and see that medicines are there. Like for instance, Nama Clinic, senior citizens are saying that you get medicines for 15 days and you don't get for another 15 days, or you get sometimes, you don't get sometimes. Same with lab facilities. Sometimes they'll do the test, or sometimes they'll refer you outside. So that consistent delivery of care in the public hospitals is not happening. We also have a lot of these commissions. So, for example, someone might get an ambulance, which is a government ambulance. They might be getting a commission to route the patient to a private facility. ಸೊ ದೇಲ್ ಸೇ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಹಾಸ್ಪಿಟಲ್ ಸರಿ ಇಲ್ಲ, ಅಲ್ಲಿ ಎಲ್ಲ ಸೌಲಭ್ಯಗಳು ಸಿಗ್ತಾ ಇಲ್ಲ, ಅಲ್ಲಿಗೆ ಹೋಗೋದು ಬೇಡ, ನೀವು ಡೈರೆಕ್ಟ್ ಬೆಂಗಳೂರು ಹೋಗಿ ಅಥವಾ ಹುಬ್ಳಿಗೆ ಹೋಗಿ, ಸಿಟಿಗೆ ಹೋಗಿ. So regulating that is actually very difficult. And now with insurance, the people are actively being routed to private facilities, in the name of like say someone has a chest pain and they have a like some telemedicine or something. The doctor in the corporate hospital say you come here. So they bypass some of the district hospital and some of the government hospitals, and they go thinking that it's free, but it's often not free. They end up paying out of pocket. They end up getting more discriminatory treatment than someone who pays. And people are given a choice at that point. They'll say, look, this is a government thing, no guarantee. ನಾವು ಗ್ಯಾರಂಟಿ ಕೊಡೋಕ್ಕಾಗಲ್ಲ, ಯಾಕೆಂದ್ರೆ ಇದು ಗೌರ್ಮೆಂಟ್ದು ಕ್ವಾಲಿಟಿ ಗೊತ್ತಿಲ್ಲ. ಇದು ನೀವು ಇನ್ನೂ ಒಂದಷ್ಟು 50,000 ಕೊಟ್ರೆ ಅಥವಾ 20,000 ಕೊಟ್ರೆ ನಮ್ಗೆ ಇನ್ನೂ 1-2 ವರ್ಷ ಗ್ಯಾರಂಟಿ ಕೊಡ್ತೀವಿ. So people are being made to make these choices. So it's not like with empanelment or with government health insurance, Ayushman Bharat, that people are getting better quality of care. And it's a misconception that if you can pay, you get better care. Because there, what happens is, till you have health insurance, they will do unnecessary tests, unnecessary procedures. Buy one, get one free. Like, get one kidney removed, and we'll also remove your gallbladder for free or something. All of that is happening. Medicalization of normal things, uh, unnecessary procedures, unnecessary tests, and all of this is happening. So I think Just asking for more budget to the public sector is not going to be enough. Like we're seeing in Bijapura, from the last 2 months, people from different groups have come together to protest against handing over of the district hospital to a private medical college. Last week they had a Rangoli Chalavali, uh, because they were saying, men are dominating the protest. So the women took over, and it was such a beautiful resistance. It was colorful, it was fun, it wasn't like everyone serious, and it was like women celebrating their practice, but also sending out a clear message that we oppose this. And I think that is important to, those spaces, that those spaces should be created. um, and I think it's also important for people to have information,
Yeah.
because there's so much misinformation. There should be sources that they can trust. I think that is where some of us play a role, like taking some of these two communities, so it legitimizes what they already know, and then allowing them to take it up in whatever way they feel is best for them.
Yeah, that is something like really important for us to look at. And I think we've come to the almost the end of the session. If anyone has any questions, I think we can engage with those questions now.
I saw some hand going up.
Yeah, I think that was my hand. That was actually, yeah, that was my, when you mentioned that institutions. So I studied in a school in Chennai, which made me sit outside because I got egg and some meat. So I have turned vegetarian because of that. And like whole of my family, they are non-vegetarians, but only me and my sister, since we studied in that school, we have been vegetarian, and we are still not able to like come out of
That is
whatever.
abuse, right?
Yeah, so not,
Systemic abuse, yeah.
yeah, so we, even though like I physically, meat doesn't do anything to me, like mentally it has been really difficult to like consume meat and enjoy the taste, because that kind of things have been like imparted in us. Punishments have been given for taking food. So that was something, yeah, like I think as a like schools, I don't think they should be like a space where food is being controlled, like personal choices are being controlled. That what?
Segregation is happening in the IITs now.
Yes.
Yeah.
Okay. Mm, no questions. Okay. Divakar. Yeah, you can ask
Yeah.
Divakar.
Hi, ma'am. So I'm Divakar from Chennai. So I've seen all your posts and I've been following your profile. So as Sangeeta mentioned, no, I also wanted to ask a question regarding this, the diet and nutritions which are influencing the school students. Now we can see many social media influencers, they are promoting all this vegan diet
Oh, yeah.
in social media. And I wanted to ask, because these people are getting invited to school as a chief guest, and these people are creating a narrative to the young students saying that meat is toxic and you have to have more compassion towards animal. So they're bringing all these narratives to students, and these young minds, growing up, they think meat is very toxic or it's unpure, saying all those things. So what is the practical solution to, is there, if does government should bring any policies or any, the education ministry should take a step to stop this, or what will be the practical solution for? And also this vegan, do you really think, is it possible for a country like India to, which is very unequal in economically in all the way, do you think it's practical for people in India to follow a vegan diet? So that's my question.
You already know the answer to that
Yeah,
question.
yeah, but I just want to know your
Yeah.
perspective or something.
Yeah. See, the thing is, like we discussed earlier, there's so much misinformation. It is easy to manipulate that misinformation. So for example, like, okay, I mean, if you look at vegetarianism, because they take animal source foods, and if it's like the vegetarianism of, say, the elite who are informed, so it's not like elite vegetarians are all healthy, because if they're eating like ultra processed foods and a lot of junk foods and unhealthy foods, they're also going to suffer from obesity, diabetes, hypertension, all the non-communicable diseases. And if the vegetarianism is like cheap vegetarianism, like cereals, millets, very little of other things, and uh, it's primarily cereal and millet driven, then also they are going to be unhealthy. They're going to have a lot of health problems as children, with more of likelihood of stunting and undernutrition, anemia, and even as adults, they are at risk of non-communicable diseases. But if, say, a vegetarian meal is well planned and balanced with diversity, they can still manage to have good heights and weights and good health, which we see in Haryana, because in Haryana, they have good heights and weights, even though a lot of them are vegetarian, because of the consumption of milk. There is a lot of consumption of milk. But with a vegan diet, there's no way that a vegan diet can be healthy, because it doesn't have the essential nutrients that it needs. And veganism, the way the language that they use is very tricky. So when you talk about nutrition, they'll shift to animal love. When you talk about animal love, they'll we shift to climate change. So it's difficult to pin them down. I'm sure you know about Arvind, the animal activist, and he was like, "Oh, Dr. Sylvia is scared to have a debate with me." But you can't debate with someone who's illogical and irrational. You can have a debate which is rational. And A vegan will not get many nutrients. For example, iron. You have heme iron and you have non-heme iron. So heme iron is only from animal source foods. It's better absorbed, it's better quality, it's better bioavailability. So if you're eating vegan food, you are not going to have access to a proper iron. You also have vitamin B12, which they have to take via a supplement. And the supplement, if you have to choose between a supplement and you have to choose between food, anyone with common sense will say, I'd rather get it from food. But the vegans are saying, oh, why don't you give everyone supplements? Which is so illogical. And in fact, even some of these, like the Eat Lancet Commission, which is pushing for plant-based diets, are also using similar language. They're saying, instead of giving meat to adolescent girls, give them tablets. They're actually saying give tablets. They're saying give supplements. So it is so bizarre to tell an entire population that instead of eating your traditional foods, you eat tablets, you eat supplements, and to get away with it. So someone who's going to schools, they have to be countered. And I think these kind of discussions, taking out information to people, I think that is the only way forward, because once people have the information, then they handle it in their own ways. People need that their practices to be validated and legitimized. I think that's very important. For example, organ meat. Many communities know that organ meat is very nutritious. So even if they cannot afford, say, the cuts, which are expensive, or boneless meat, they will still buy organ meat. And it's tasty. The children eat better when they have access to that in their food. It's one of the best, most nutrient dense foods, organ meats. And when you say should governments do something, governments are not doing anything. If you look at the Ministry of Women and Child Development, WCD, they put out information on anemia, and they say eat lime, eat greens, eat millets. They are the best source of iron. So the ministry itself, the Ministry of Health or Ministry of Women and Child Development, or even the ministries of who related to food and nutrition, they are putting out wrong information, misinformation. So we cannot completely depend on the government to do this. We have to challenge even the government's health education messages, which reinforce again this whole casteism. It's, I mean, I think there is a shift, because there are people who are coming forward to challenge this mainstream narrative, and they should become mainstream, so that people then will eat whatever they want. No company or no government or no teacher can force you to eat something if you know that that's not healthy for me. Once you know what is healthy, then I think people will choose to eat it. Without that knowledge, I think that's what makes people vulnerable.
Yeah. Naveen has one question. Yeah.
Yeah. I yeah. It's more of a question, I think, for all of us to. Sorry. Okay. Um, I've, we've been sitting with, because we've been working in the Chenpatna Health Library and the reproductive health cultures, and oh, Sylvia has left the conversation.
Okay.
We'll wait.
We'll wait.
Some internet problem.
She's back.
Yes. So a lot of it. So, and this thing
Can you
about,
repeat
yeah,
the
sorry, I
question?
had paused. I had paused. I was saying that when we are working with the Chenpatna Health Library, where we work with community health workers, not the ASHA workers, but health navigators, they're more private. And then also in the reproductive health cultures work, what is, at least for me, what is emerged is there's a lot of this YouTube or Insta, mostly YouTube driven information or misinformation around what is healthy, and what is healthy food, and often it is at odds with the knowledge that people carry and hold over the years, and that is local and that's very specific, versus there's this more kind of a global coming from Bangalore or somewhere else that is being translated or coming through. And but if we in our work, what we're trying to do is to set up these making the local knowledge more visible, which I'm now thinking that could also be thought about in the frame of misinformation and easily rejected by policymakers, whereas a certain other voices can be given more prominence. So when everything, the veracity of it in the way that the knowledge is being shared is always under question. So how do we think about saying that this is more, this is valid in the context of where it is coming from? And how do we establish those frames of validity?
I mean, we have the science.
Hmm.
I think there's very strong evidence,
Hmm.
even from India, about exactly the foods that people are being told to reject.
Hmm.
So I think those two should be combined. So when you tell people about, like for example, if you say organ meat, and they say, yeah, we eat organ meat, and you say, yes, research shows that that is the best food that you can give your family. It's that's why, uh, it- because what people are pushing as research and evidence is actually a lot of more like ideology, mythology, grandma stories. I read in my ancestors or something. It's not based on science. So I think we need to really, because we are not, like, say, as a public health doctor, I'm not going to say, oh, this is traditional, just give it to people. I
Hmm.
also need to look at the evidence and say, yes, actually evidence also says that these foods are good. And that's how I bring my argument in. So it would be unethical of me to, because that's what people are saying. They're saying this is our ancestral food, this is our culture, and pushing all these wrong notions. So we don't just say culture and tradition is you know the all and end all. It is that it is actually legitimized by research. So, and I think pulling out the research, because
Yeah.
again, like you said, even research is corrupted, it's
Yeah.
contaminated.
Yeah.
You get equal papers on both sides of the argument. uh, so not just looking at research but also looking at methodology, and showing that a certain methodology is superior and therefore that research is much more legitimate. I think that that's like a full-time job. uh, just if you look at anemia, and if you look at the nonsense that researchers are putting out in India. So first of all, they're trying to say that anemia is not at all a problem. They're saying they looked at data which is it's like saying, I'll take 100 people who have anemia, I'll take the average and then say that average is the standard for the country, instead of saying I'll take 100 people who are healthy, who don't have anemia, and who are very well nourished, with balanced diets over 2 generations, and then take the average and say that will be the standard for the country. That there is a difference between both. Then they also take a diagnostic test and screening test, and say that, like, I mean, it's a bit complicated. We are bringing out one article on that, so I won't go much into that. But to say that the cutoff itself. So, for example, if the normal cutoff, which international standard for anemia, is a hemoglobin of 11, they're saying we don't need 11. Indians are different, genetically
Yeah.
different. Let's reduce the cutoff. So then your anemia itself disappears. So that's the kind of bogus research that is happening. Then people pick it up, and now they're not even studying anemia. Together, then there's no stopping people. I think there's no stopping people's uh, validation of their own practices with science.
Right.
There is one question from Abhishek. He has put it in the chat box. Do you want to ask it directly, Abhishek, or
Yeah, Abhishek, let's hear your voice.
yeah?
To unmute, I think. Was he speaking? Oh, he's can't.
Can't.
Okay, fine. You can read it.
Yeah, I can read the question. So, as you said, that food practices are deeply rooted in caste, which also means that food we eat is decided illogically, in ignorance rather than informed decision. Egg, for example, required a lot of effort from the state for decades to now being accepted as a nutritious food, even among vegetarian caste groups. How do we work with societies in this case to bridge this gap? Can civil societies reduce this gap, or is it possible in a successful way if only state intervenes?
I think we touched upon bits of it. Is I mean, with eggs, it's interesting because all the nutrition bodies, whether it's National Institute of Nutrition or UNICEF, WHO, they have clearly stated that there are benefits of egg. Then you have organizations which come and say eggs are menstrual discharge of the hen. It is tamasic, and you shouldn't have it. And again, they associate all the tamasic qualities with the egg, and they get a priority by the state government, and they are allowed to give food. They are allowed to dictate whatever is happening. Even after the government has said so, first of all, initially there was more resistance to eggs. I mean, there have been campaigns for eggs from a very long time, and there has been a lot of resistance. In fact, I think there was a plan, and then that plan got cancelled. And when the minister was asked what is the reason, he said religious reasons. That was the reason we couldn't give eggs. But it's moved to a point where even these religious groups have split their position on eggs. Even within these so-called religious groups, which had strong positions earlier, there was a split in some of them saying it's okay. That Basava never said don't give eggs. That much of a position that it came, and I think that's very important. A lot of people who are artists, theater personalities, writers, thinkers, thought leaders, cultural people within Karnataka spoke up in favor of eggs. Children came and asked for, demanded eggs very vocally. We also had across districts people giving memorandums to the officials saying we want eggs. In fact, there's a very proactive official also who took a study to assess the acceptability of eggs, and a majority of children and families in government schools said that it was acceptable for them to have eggs. And in fact, a study was also done to compare giving eggs versus not giving eggs, and they did also document that there was improvement in the health of the children. So it was a combination of people's demands, proactive bureaucrats, and it came together, and I think they started giving eggs. But there is a lot of resistance. For example, Akshay Patra schools, they are not giving eggs. They've been asking the government to form a parallel system. So they will give the food and the eggs will be given by a parallel system, which is like, the contractor dictating what the person who pays should do, which is ridiculous. It's like if I say I want a swimming pool, and then the contractor says, no, no, you have to build a library. Like, what is that nonsense? And it's literally that's what's happening. But the group that is being given the contract is dictating what food will be given. And there is still a lot of resistance. But we have visited schools in very remote areas, and the children are happy. They said, yes, we get eggs. There are gaps in the sense the teachers are not getting the money in time. Sometimes the eggs are spoiled, and they don't get the egg supply. A lot of things are there, but it's a system that has been put into place, which has to be strengthened. And yeah, soon we should start bringing other foods also to the midday meals. Why restrict it to eggs?
Yeah, 100% agree. Yeah. Thank you, Sylvia ma'am, for joining us. And I
Sorry, which is what my trolls keep uh, predicting. They said, see, now you let eggs, and see what else these people will start demanding.
yeah.
Yeah, sorry. I
Yeah,
thought
yeah.
I should say that.
No, I was just telling, we hope we collaborate more and we keep having a lot of these conversations, these important conversations, which leave us with a lot of questions to think about and to ask the system itself. Uh, and I thank everyone who has joined today's call. As part of School of Community Wellbeing, we'll be opening up courses and more public engagements soon. One public engagement which will be happening is on December 6th and 7th in Science Gallery, Bangalore. We'll be exhibiting food practices, foraging from Channapatna, and we are also having people like women from the place also in the exhibit. Yeah. So thank you everyone for joining in. Hope we can connect some other talks soon. Thank you.
And thank you so much for the work that you all are doing. Very inspiring.
Thank you, ma'am.
Thank
On
you.
behalf of
Thanks, ma'am.
LLI. Yes.
Bye.
Bye bye.
Bye, Abhishek.